Monsura Haque. Monsura Haque is a public health physician with more than 10 years of experience in managing chronic disease, especially diabetes and thyroid-related disorders. She obtained her MBBS, MPhil in preventive and social medicine and MPH in epidemiology from Bangladesh. She worked at Princess Margaret Cancer Center and McMaster Health Lab in different research projects. Currently, she is working as a case manager at Ontario Ministry of Health and dedicated serving the population and community in need. She is also contributing herself by volunteering in multiple organizations like Toronto Global Doctors Line Club, Canadian Coalition of Global Health Research, Diabetes Canada, and Lupus Ontario Toronto. Her driving sentence is preventing disease and promoting health. Monsura is enthusiastic about working on chronic diseases, especially diabetes and other hormone related problems. She is determined to explore the needs of deprived population and sorted shortfall comprehensively by the way of coordinating knowledge and communications. So thank you, Monsura, for joining us today. The floor is yours now.
Good evening, all the Lions, and thank you, Nabila, for giving me the floor. And give me a moment, I'll share my screen. Thank you, my fellow colleagues like Sugandha, Priscilla, and Aval for your nice presentations. I will present the complications of mothers who have the GDM. So now I am starting my presentations. So my portion is the maternal complications with GDM, and I'm Monsura Haque, and I am the proud ITMD from cohort 12. So around the globe, actually, 1 in 50 to 1 in 20 pregnant women has the gestational diabetes or diabetes in pregnancy. So it is more common in the Native American, Alaskan Native, Hispanic, Asian, and Black women, but also it is found in the white women also. So how the GDM affects the mother? So the placenta, which connects the mother to the baby, as Priscilla says, so this placenta really produces varieties of hormone to maintain the pregnancy. Why it produces those hormones? Because otherwise the body recognizes the fetus as a foreign particles and destroy them. So some of these hormones can have the blocking effects of insulin and prevent the actions of the insulin. So this is also called the contra-insulin effect. How they act? Usually their structure is similar with the insulin. They compete with the insulin and prevent the entry of insulin into the cell and insulin, so that the insulin cannot work as well. So it usually begins about 20 to 24 weeks in the pregnancy. And as the placenta grows, more of these hormones are produced and the risk of insulin resistance become greater. So what are the complications actually happens? So these are the, firstly, we can divided this into the hypertensive disorder. There's 3 types of hypertensive disorders may happen with the mothers. That is, one is the chronic hypertension. So what is the chronic hypertension? The mothers who have already hypertension and continue as a hypertensive mother. And some is also like preeclampsia. Some of we know about these things, which develops around 20 weeks of pregnancy. That is, hypertension develops. It also, along with some other organ failures, maybe the involvement like kidney or liver. And also the gestational hypertension, this is only include the hypertension after at 20 weeks. This is only the hypertension, not involves the other organs. So preterm birth can happen, that is the delivery of the baby before the completed 37th week of pregnancy. Postpartum hemorrhage, that is bleeding after the delivery. usually 500 to 1000 ml, that can be very fatal to the mother also. And this is the shoulder dystocia that happens to the child or newborn when their shoulder is stuck with the mother's bone, that is pelvis, and it needs the assisted delivery. So it can harm both the mother and the fetus, so mother and the newborn baby also. So then the C-section or cesarean delivery, it is much higher in case of maternal mothers who have the GDM. It is around 47%, and maybe around it may be double in case of GDM patients who have the diabetes. And it is also said that GDM or gestational diabetes can be a cause of the cesarean delivery. It can taken as, okay, he has the GDM, so we need the cesarean delivery because the baby is a big. So even some mothers develop some long-term metabolic comorbidities, which includes like diabetes. She can continue as a diabetic patient, and also the hypertension, and that may lead to other complications also. So what about the things like, what is the warning signs if somebody has the gestational diabetes? And like we can, like if she has the gestational diabetes, the main thing is that we should check about these symptoms, like of hypoglycemia symptoms, like she should not be, like if she feels sweaty, hungry, racing heart, headache, or irritable, then we can consider she may be hypoglycemia, her blood sugar may be low, and that can be very fatal to the mother as well as to the baby. So we should consider them as a very emergency, and we should feed them and give the necessary treatment. Also, like what is another one is the preeclampsia. We should always look after these things. If somebody someone like gestational diabetic mother has the blood pressure is above 140/90, having some like swelling in the leg, so like have a severe headache, changes in the vision, or maybe the abdominal pain, and nausea, vomiting. So we should take care of these symptoms, and we should seek emergency medical care to the primary care physicians, and we should inform them. So there's so many people having the gestational diabetes, but no, everyone not developing the preeclampsia. So who is at risk for developing this preeclampsia? So it is also told that who is having the first trimester obesity, like who is already obese, or in the first 3 months, she has like BMI is more than 27, he is obese. And also like excessive gestational weight gain, somebody has like in the pregnancy, her weight is gaining too much. So it is a modifiable risk factor that can be changed, and it is a predictive factors for the preeclampsia. And also, like if somebody diagnosed as a GDM or gestational diabetes prior to 20 weeks of gestation, that is before 20 weeks of their gestation, and who don't have the blood sugar level in control, so she should as a risk factors for preeclampsia. So what are the long-term complications happen to the mother? So somebody develops in the hypertension in the pregnancy, then she can continue as a hypertensive patient, which can lead to the cardiovascular disease or heart disease. And this is the one of the complications. And also some of the mothers can develop the metabolic syndrome, which can be like visceral obesity, that is the fats are accumulating within the viscera, like maybe the stomach in the abdomen. So like it can be pear-shaped abdomen, or hypertension, insulin resistance, or blood sugar level may be altered. These two types of cholesterol, one is good for health, one is bad for health. So someone is having the high TG, that is high bad cholesterol, or low good cholesterol. If any among these 5, if 3 are present, we consider them as a metabolic syndrome. So GDM mother can develop this one also. So woman with GDM has 7.43 times the likelihood of developing type 2 DM as pregnant woman without GDM. So how we prevent these things? So we have 3 steps of doing these things. Like we can do antenatal management. If somebody develops GDM, we can manage them. And if somebody had developed GDM in the postnatal, we have some steps to follow. So in the antenatal management, as per Sugandha and Priscilla said, so we should do preconceptional counseling. So like we should consult with our nutritionist and having the nutrition therapy as well as per their advice. If somebody is obese, there should be weight management and the exercise and the drug therapy if they require. If somebody develops diabetes in the pregnancy, they should continue with these nutritional regulations and lifestyle modifications, and also like self-monitoring of blood glucose as per Wolf said, and the drug therapy, mostly insulins are given, and blood pressure, if it is more than 135/85 millimeter of mercury, should be treated, but not less than 120 to 80 millimeter of mercury. That can harm to the newborn also. In the postnatal, what happens? We should take care of the mother so that we can prevent their further complications. So we should screen at 4 to 12 weeks after the delivery. And if they are pre-diabetes, should receive intensive lifestyle interventions or drug, and lifelong screening at least every 3 years if they are normal. And also we should give them psychosocial assessment and support for self-care. So what is my take-home message from my presentation? Please check your blood sugar before planning for conceptions, monitoring and maintain blood sugar and blood pressure throughout the pregnancy. Follow up blood sugar after delivery at a regular interval. Everything is going to be okay. So you can search these things from these articles. And if anyone diagnosed with pregnancy, diagnosed with the diabetes in pregnancy or around you, or having any questions, you can ask all of us. And I am Monsura Haque. You can email me at this email address. Thank you so much.